Hey there, it's Dr. Sarah here. Welcome back to another episode of the She Found Motherhood podcast. Today, I have the pleasure of chatting with Sarah Stetina, a registered midwife at the Burr Ridge Birth Center in Illinois. Sarah and I have a really great conversation around the differences in giving birth in a birth center and a hospital, both here in Canada and the US. And really, we take a deep dive and have a conversation around philosophies towards providing care for people during pregnancy, labor and delivery, and postpartum. Can't wait to get into it right after this quick message. Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
Good morning, Sarah. Welcome to the She Found Motherhood podcast.
Hi, thanks for having me.
Oh, I'm super excited. I love that we both got on and we're like, what are we talking about? But I actually think it's going to be a really interesting conversation for people to hear. So why don't you start by introducing yourself, telling us a little bit about who you are and the work that you do and what we're going to talk about today.
Okay, my name is Sarah Stetina. I live in Illinois in the United States, and I am a certified nurse midwife for the last 5 years. And I'm now currently the Director of Midwifery at Burr Ridge Birth Center, which is a freestanding birth center, the third that opened up in our state. So it sounds like we're going to talk a little bit about the differences between the US maternity care system and the Canadian maternity care system, and maybe what birth centers are, since they don't seem to be a thing in Canada. So
I could be wrong. They're not a thing where I am.
okay.
Yeah. So I can share a bit about what the system is like here in Canada, and then you can compare. So here in Canada, generally speaking, you can choose to give birth in our province. And in the region I'm located, you can either give birth at a hospital or at home. There may be some birth centers in other areas, but I'm not too sure. And I'm sure people will comment to us once we've published this podcast. So generally speaking, we do have family doctors and midwives as well as obstetricians who provide primary maternity care here. I'm a family physician with extra training. I only attend hospital births. I'm not trained in home births. And I think everybody who is super brave and amazing. And midwives will attend home births for a very select patient population that's generally considered low risk. And we've done a few podcasts on home birth. We've interviewed a few people about their home birth stories, and they're always just so incredible to me. And they're so beautiful. I could never have given birth at home. My pregnancies were complicated, but my births were always. Anyways, so generally speaking, that's the sort of primary care model for intrapartum, so labor care. In terms of while you're pregnant, people generally go to their physicians or their midwife's office for their prenatal appointments. And then afterwards as well, once you've been discharged from the hospital, you'll go to your physician's office for appointments. Whereas with midwives, and I'm only speaking from like our local experience, so midwives will generally do home visit for follow-up. So they'll go and see their clients and their newborn babies in their home. And then I know some of the midwifery groups here have some like group visits at their site. We used to do group visits before COVID, and we'll probably get back into that again. That's sort of a general little overview. And you could share about how you guys do yours down there.
Yeah, it sounds pretty similar, except for the addition of that like third level, which is the freestanding birth center. Most babies in the US are born in the hospital with an obstetrician, but we do have family practice physicians that are able to do births. They're just much less common than an OB. And then we have several different types of certified or midwives. So we have certified nurse midwives, which went through nursing school first and then went on to get an advanced practice degree. So they're like nurse practitioners, but specialize in midwifery, birth, all of that. And then we also have certified professional midwives, which aren't necessarily nurses first, but go through a midwifery program. There are certified midwives. There are traditional midwives. We've got all different routes and pathways to midwifery, and all of those midwives have different legal statuses in different states. So it's quite confusing for the consumer in the US, but certified nurse midwife is what I am. And we are legal in all of the states and practice in all three settings. So the hospital, birth center, or home birth. And then there are some midwives are like certified professional midwives that exclusively do home birth or out of hospital settings like birth centers. Birth centers are the littlest population of where babies are born. We are growing every year of people who know about us and choose us. But so overall, it's hospital, then home, then birth center. And similar to what you explained, clients find their provider during prenatal care. They go to an outpatient setting like an office for prenatal care visits and then go to their designated space for birthing, whatever they choose. Home birth midwives will sometimes have their own clinics as well or meet clients in their home.
I think birth centers sound amazing. Can you share a little bit about what a birth center is and do people have to qualify to be able to birth there?
Yeah. So a birth center it's freestanding, meaning it is completely separate from a hospital. So in the US, a lot of hospitals have labor and delivery units that they'll call a birth center or a birthing center or family birth center or something like that. But that's not a true birth center in the sense of the definition, which is a building that is completely outside and separate of a hospital. And it is designated for low risk pregnancies. So we do have pretty strict criteria for who can enter care at a birth center, who can continue care at a birth center, who can actually labor and birth at a birth center. The midwives are touching in on that criteria throughout care and throughout the labor process to make sure that this is the appropriate place for the client to be. We have the benefits of birth center essentially is that you get a low risk, low intervention approach with really great outcomes. So we obviously have all of the outcomes that come with a low intervention approach, which is low C-section rates and all of that. But it's really evidence-based practice and it's very nice for some folks who feel a little uncomfortable with being in a home setting, but know that they don't want to be in a hospital setting. And so it's like that sweet spot right in between where we call it like the hospital is the physician's home and the birth center is the midwife's home. Yeah. And for clients who want that approach and don't want medication, we obviously don't do epidurals at the birth center or anesthesia. We have a lot of other tools to ensure clients are comfortable and coping well with labor, but it's a great option for those folks.
It sounds so amazing. And I honestly wish, and hopefully someday we will get them here because I agree. Like I always say, intervention begets intervention. And there's nothing wrong with intervention when it's medically appropriate, but it's just so much easier to do that in the hospital setting. Whereas if you're in a birth setting, a birth center, and it's safe and you've got access to everything you need to have a low risk birth, I think it's easier to go down that path, if that makes sense.
Absolutely. I've practiced in a hospital setting as a midwife and as a nurse. And even when I worked in a hospital setting, my philosophy was the same. I wanted to approach birth really low intervention, but you're right. Just having that space, you reach for those interventions because they're there. In a birth center setting, you do have to think through, is this intervention truly necessary? Is it worth changing this client's entire plan to move them to a whole new setting? Or can we find a solution and still keep it safe? And it has definitely challenged me as a midwife, but it's been awesome because my stats have changed dramatically in a year of practicing this way.
Yeah. And I just think too, the pressure of the external, like the Canadian healthcare system is very different than the US, but generally speaking, like we're super taxed right now. We don't have enough nursing staff and we're like, and someone's really busy. So there's a pressure to like get like labor's getting started and okay, sure, waters haven't broken. Let's do an ARM. And you think it's low risk, but it can change the course of a labor if we don't do it with appropriate time and consideration. I think it's such a beautiful option for people.
It really is. The pressure of time is such a good concept because even in that hospital, as a provider who wants to provide that time, you feel the pressure from everyone, from the whole system. And at the birth center, we have that. We have time. We have the patients to just wait for labor to unfold. And it takes a lot longer or shorter sometimes than what we've been told or what we see in a hospital setting sometimes.
And if people do need to be transferred, so say they develop like a fever or abnormal fetal heart rate, how difficult is it to make that transfer and how can you do it in a timely fashion?
Yes, it varies from state to state on as far as what the regulations are. So some states don't have any regulations and they can start a birth center anywhere. Some, they're not allowed to even start a birth center. So again, the US has the challenge of having all these different states dictating and things can look really different from one place to the next. So I can really only speak to Illinois, which we are required to have a relationship established with the hospital before we can even open our doors. And that I think is a great thing, but also a barrier because some hospitals don't want to partner with birth centers. We were really fortunate to have a really amazing facility within 3 miles of our location and an amazing EMS team that helps us get our clients there quickly and safely. And so we've worked really hard with being well integrated with them. So we are separate entities, but we drill with them, we practice, we sat down and had conversations with their physicians, with their midwives, with their nursing. And so everyone knows what that process will look like. And also, like, why our clients even choose this, because it's a huge pivot when someone wants an out of hospital birth and a community birth and then have to go to the hospital for safety reasons. And so having a team of nurses and hospital providers who understand that and are really emotionally supportive of a client and not going to belittle them or punish them in any way for that choice has been really beneficial. So essential to have that relationship, but not always possible, unfortunately.
Oh, it sounds like you guys have a great setup.
Yeah, we're really lucky. It was very mindful, thought out, took a lot of time.
Yeah. But you know what? Good things do take time, right? And now, do you have, so when your patients and your clients are laboring, do you have nursing staff there to support them, or are they supported primarily by their midwife?
It's a great question. So we have our birth center staffed with certified nurse midwives and registered nurses. During labor, it's kind of the opposite of a hospital where a labor nurse may labor with a client and then they call the provider in towards the end. At the birth center, our midwives labor with our clients and we call the birth assistant in towards the birth so that in the event of any unforeseen events or emergencies, we have our birth assistant nurse to assist us in that moment.
That's so cool. And then tell me about afterwards. Like, how long do they typically stay and what the care looks like?
Much different. So in the US, a hospital stay is on average about 2 days. Often now, more recently, especially with COVID, earlier discharges around 24 hours have definitely picked up and been more common, even with OBs. But at the birth center, our clients stay for 4 to 6 hours and then they go home. And
Wow.
so they can stay up to 12 hours, but we are considered a short stay facility. So clients who need to stay longer than that or having need for observation, we do recommend they go to the hospital at that point. But most of our clients, if they've made it through their whole pregnancy low risk, they've stayed at the birth center until the baby has been born and it was an uncomplicated vaginal birth. They had an immediate postpartum that was normal. Most of them feel really ready to go home in that 4 to 6 hour window. And most of our care during the prenatal period is really intensive. So it's very heavy on education. And so our clients feel really ready to go home. Whereas in a hospital setting here in the US, most of the education around postpartum happens in those 2 days that they're at the hospital.
Because if you don't like have any brain capacity for learning at that point, right?
I know it doesn't make sense a similar approach to go off of that is we do all of our informed consent prenatally and we talk through all of the potential interventions that we can or could do or might come up during a labor. Even things like vitamin K and eye ointment for the baby, we talk about prenatally because to make that decision in the moment after you've just birthed someone or are laboring, it doesn't actually seem like a true informed consent. Our clients really appreciate that difference too.
Oh yeah, it's so great. It's funny. I don't know. You probably know we have an online course that Alicia and I have made, and
Yeah.
yes, and a big reason we did that was because as like physicians working in the Canadian, like we have a fee for service model, meaning like we have to see patients. We have short amounts of time to see patients because we get paid very little per visit. And so we built
Mhm.
this course that has information that we wish we could give our patients in the moment, but because of the model of care that we're working under, because it's so true, right? Like you can't truly understand if someone's trying to sit there and explain to you what forceps are, and you're just like, they're like, we have to do it now because maybe you're just like, whereas if you've learned all of this beforehand, you can be like, yeah, I know I had forceps. And I was like, don't need consent, just do them. Because I knew the risks and I knew the benefits and the risks of not doing them. But not everybody has that education beforehand. So it's so important. And it's amazing that you guys can do that. It's interesting because, and then one more question before we go on to a nice philosophical debate. It's not really a debate. I think we agree. So then I presume you do home visits postpartum?
So many birth centers do home birth visits. As a new birth center with really limited staff and resources, I think we just don't have the capacity to have our midwife driving
Yeah.
to see our clients. So they do come back to the facility at 24 to 48 hours
Yeah.
for their first visit. So they do come back. It's our goal eventually to have that offered because I think it's so nice. If you're sending them home that early,
Yeah.
to then have them come back is not the best, but right now it's what we can do. Some practices do home visits, which is great for families. And then to just assess them in their own setting is such an added benefit
Yeah.
of that. And even breastfeeding support in their own home can be so helpful. But right now, they are coming back to our facility for those postpartum visits. And we do have quite a few touch points for the postpartum period. Our birth center also provides newborn care for the first 2 weeks. So our midwives in the US, certified nurse midwives, newborn care for the first month of life is included in our license.
Oh, that's great.
Many of us don't actually do that, but this is the first time in my career I'm doing newborn care. And it's been awesome because then we're caring for the couplet as a dyad together. And that's given us more touch points with our birthing person too. So we see them at 24 hours, 4 to 6 days, 2 weeks, 6 weeks. And so we've got these 4 visits where otherwise they may have only had one, which is really great.
Yeah. And we're really fortunate as family physicians. We do the care for the dyad, like the mom and the baby or the pregnant person. And exactly because we have to see the baby so frequently and the parents come with the baby. So you have these touch points where you can not only connect. So it's the same thing, like we see them at 3 or 4 days and then usually a week and sometimes even 2, 4, 6. And it's so much more empowering for them to have that support and the check-in because postpartum is hard.
It is. And it's so isolating. So it's nice to have those built in as just like our routine.
Yeah. And I also think there is some benefit to making families come to you because it forces you to get out of your house. Like
Yeah.
I remember when I was postpartum with so many kids, I realized that I'd been home in my house for a week straight because the only reason I was going out was for visits because it's so overwhelming. And so it's a bit empowering to be like forced to take the baby out. And then you're like, oh, we can do this. And then it's another forced outing. And then you can get a coffee after. And then you start to be able to do these little things that make you human instead of just
That's so true. So true. I feel like so many families are like, this is our first time out of the house with the baby and we did it. Like it happened.
totally. And you're like, yay. And it really is a big deal. Like I remember being so proud of us when we took our first son to like infant and got him in the car. And yeah, totally. The longer you put it off, the more like overwhelming it.
Yeah.
Is this pain I'm feeling in my pelvis normal? Should I do genetic testing for chromosomal differences in my baby? Is it safe to go to the dentist while I'm pregnant? Doctors and maternity specialists Sarah and Alicia are here to empower you with even more knowledge so you can have the best pregnancy, birth, and postpartum experience you can. Presenting the Pregnancy to Parenthood podcast, a new series of informative episodes geared week by week toward whatever trimester of pregnancy you're in. Tune in weekly, following along relevant topics as you move through pregnancy, or just binge listen and come back to the episodes you found most helpful. Access the full series for a full 2 years and listen to it on your own time. To learn more, go to www.shefoundhealth.ca or click the link below.
Leading into talking about obstetrician, and like I did, so as a caveat for those listening, I actually started my training in OBGYN. I didn't know if you knew that. No, so I did 2.5 years of the 5-year Royal College program, and then I switched into family medicine for multitude of reasons. But I remember when I was training, I was like, I didn't like doing low risk birth. And I didn't like, because that's not what I was, my skills were not, I wasn't training for low risk birth. I was training to do operative procedures and caring for complicated pregnancies. And here in Victoria, we're really lucky that our model doesn't actually have obstetricians doing primary care. So you can only have primary care by a family doctor or midwife. And obstetricians are there providing supportive care and then on site for any complications in birth. And it's funny because I know it's very different in the US, but I was talking to one of my colleagues and she used to be one of my staff when I was an OBGYN resident. And she's, oh, I couldn't do primary care. She's like, I don't know anything about babies. Like, she's like, they come and ask me about the baby or breastfeeding and I don't have that training. And then they are like geared, like, the training is about intervening.
It's fixing problem.
Yeah. And that's why, and it's funny, you say that because that's exactly why I went into OBGYN to begin with, because I was between family and obstetrics. And I was like, yeah, but I want to be able to be the one, like, if there's an abnormal fetal heart rate and they need this, I want to be able the one to help provide it and fix the problem. And then I switched mostly for personal reasons. Like, I wanted to have a family and I wanted more time and I didn't work as much. But exactly, like, the whole training is not geared to low intervention and primary care.
Yeah, I think that is at the root of it, why we have the outcomes that we do, at least in the US, when, like I said, a majority of our clients are going to the highest level of care for a process that most of the time is completely normal. So we have, it's, the best way I explain it to families when they're trying to understand why they would choose a midwife versus an OB is, if you're going for an annual wellness visit, you're going to go see your family practice physician. You're not going to go straight to a cardiologist. You're going to go see your family practice physician. And if there's something that they identify as an issue with your heart, then you'll go see the specialist. And so that's how I've always viewed it, as like midwifery is the entry level for most maternity care. And if there is something that develops that is complex or that is abnormal, then we default to our obstetricians. But that's exactly the opposite of what happens in the US. And I think from just what I've seen on your page too, it sounds like there's a mutual respect between the family practice physicians and the midwives in Canada, and the referral base goes both ways depending on what clients are seeking. And we haven't gotten there yet in the US. I don't think a physician has ever referred a client to me, even if the client has expressed the desire to birth out of a hospital setting or to birth with someone that wants to do low intervention or have an unmedicated birth. And they're usually just advised against that rather than directed towards a provider who does know that information or who is good at that. So we have a lot of work to do in the US to make that a little bit more common.
Yeah.
Like all the other countries, like England gets it, you guys get it right.
Yeah. Yeah. And I wouldn't say that it's like this everywhere. I think we are in a very forward thinking center. But yeah, it's so fortunate. I don't have a family practice anymore. I do mostly hospital based care now just because of my life and the chaos. But when I had patients who, like family practice patients who wanted to go to midwife, I'd be like, oh, I'm so sad. But I'm like, wait a second, this isn't about me. You want home birth. You go, girl. And some people would be like, I just really want the after visits in my house. And I'm like, I'm not going to do that. So have at her. And I absolutely like, one of the big areas of work that I do is perinatal addiction. So I work with pregnant and newly parenting folks who have a history or active problematic substance use. And we, as best we can, try and connect all of our patients with midwives for their actual maternity care. And we do the sort of addictions and the medical piece because because as you said, like midwifery is much more trauma informed model of care than any medical system, right? Because typically you have lower number of providers, you have longer visits, you have that capacity to allow for the time and the space for people to feel in control and empower. And I think doing that work has really increased my appreciation for all the skills that midwives have that just totally go unnoticed.
It's a completely different specialty. Like it's very unique. And I feel like there's a role for every provider as long as they're utilized in the way that they are trained. It sounds like you guys are doing that really well. That's amazing.
Yeah, our center, I feel like I'm tooting our center's horn, but it's really interesting because the chief of staff or whatever, she's a OBGYN, she's an MFM, and our model has we have some of the best outcomes in Canada because we have this tiered model where lots of our low risk patients go with midwives. And then those that are like higher risk have primary care by us physicians who can help co-manage like their high blood pressure, their diabetes. And then we have the obstetricians that are there overseeing and offering us support when we need it. And we have great outcomes because we have people providing care at the level at which they're trained.
Yeah, that the numbers don't lie.
Totally. And I don't know what the best way forward is in terms of supporting other centers. Like even in Vancouver, which is just across the water from us, they still have lots of obstetricians doing primary care. And I don't know how we continue to promote this model of care and how in the US you start to empower midwives and also empower physicians to be comfortable referring to midwives.
I think it's improving. One big component is a lot of academic centers now in medical, university medical centers have established midwifery practices. And so their OBGYN residents and family practice residents will sometimes go through their rotations with midwives. And I feel like once they work alongside each other, you're just establishing that mutual respect of the value of the two different professions. And that you can, when I meet a physician who did a residency with midwives, I know, I can tell, they have a different way that they view my profession, and there is that mutual respect there. So I think that is a huge starting point, but then also just data, the more numbers that come out that kind of reaffirm what we're finding, is just
Yeah.
more and more proof, I guess.
It's so true. And I don't want anyone listening to think all obstetricians are bad because that's definitely not the case. There's some really amazing care providers out there. And that's one thing I struggle with being on social media is that there is a lot of physician bashing.
Yeah.
Will like really say, and yeah, there are some non-trauma informed providers out there and like with really high intervention rates, but that's not everybody. And so it's so challenging to find the balance of encouraging people, but also just saying, not everyone is really bad out there. Like you're going to have a good experience X% of the time.
Absolutely. And I always tell our clients, like, you want obstetricians to exist. Like you do. We need them. They are the experts of abnormal. They will fix any complication. They will take amazing care and they know their stuff. Does every single person need one? Probably not. So I totally agree. I think you mentioned a good point of the trauma informed. I feel like the last like 5 years, I've seen just this like surge and just awareness of obstetric violence and the impact that the healthcare system can have on people that we've never really heard of or hadn't heard of until people started sharing their stories. And I think the more that all of the healthcare providers become aware of those stories, we can all take a better trauma informed approach. That's when we opened our center, we kind of labeled ourselves as a trauma informed practice. And when you do that, everyone shows up with their trauma and they tell you about it. And so you have to be really prepared to take that on. But they're showing up with that trauma because they've already been traumatized in a system that isn't really serving them. We all need to find a way to do better in that regard.
Oh, yeah. And it's so interesting because one of the biggest reasons I think Alicia and I started this community, like She Found Motherhood and our podcast and our course was because I think one of the biggest things you can do to empower yourself and to reduce the likelihood of you experiencing trauma is to be educated and to be informed and to be prepared, right? We talk a lot about like birth preferences, and I don't want people to think you need a birth plan, but I'm like, you need to go through the process of thinking about what could, like you said, you do with your client, what could happen and what would you do in that circumstance so that you're like ready in the moment and you're not totally hit out of the blue that
This
you're
is even an option.
totally.
This is even yeah. Like people, you can't make a choice if you don't know what all of the choices are. And so if you're only presented with one option, that's not an informed choice. And it's so hard to know all that if you haven't actually learned about it beforehand. And yeah, education is a huge component. I think it's awesome that you have created that tool for family because there's not enough known about the whole process,
You know,
not
and
enough time.
the other thing I think we love is recording people's birth stories because, like, just listening to other people and their experiences, I think it's just, you're like, wow, like and people can have beautiful births, like whether it's like an uncomplicated, spontaneous vaginal birth at home or if it's an emergency C-section. Like it was saying on one of our a comment on a post we did. Oh, yeah, I think I did a post about what we have this saying that we can help you get your best birth by being like moving your body, practicing mindfulness, being educated and informed, having a support team. And somebody commented like, oh, I had an emergency C-section and loved every minute of my birth. And you can.
Yeah. Oh my gosh. The outcome is not the part that
No,
matters.
no.
Like everyone, of course, wants a safe baby. That's a given, or like a healthy birthing person, a healthy baby. That's a given. It's how you were treated, how you felt throughout that experience. Did you feel like these things were happening to you, or were you an active
Yeah.
participant in it? And if you knew that you were an active participant, you felt treated with respect, a whole person, then you're going to come out the other side feeling great about it because you were well cared for, that you are always going to remember that day, even if it unfolded in a way you didn't expect.
No,
I
absolutely.
totally agree with that.
No. And it's so beautiful to hear because unfortunately people are complicated and we have people who are getting pregnant with complex medical conditions or older than typically would be and unfortunately we know that sets you up for a higher risk of requiring a C-section or other intervention in birth
Right.
and it's just statistics, right? Like we'll never get to a C-section rate of 0, nor would we want to. And so just understanding that there's only so much we can control, but what you can control is like the information that you take in and the approach that your providers. I think those are the two most important things. And so we can help our patient-centered clients get empowered by information. And then as providers on the other side, we have a duty to, you're a midwife, so you're good. But I feel like I have a duty to share the importance of trauma-informed like care for obstetrical and birth workers.
Yes. I'm glad that you're doing that.
Amen. I know. Actually, Alicia and I have started, we've gotten a grant to basically do what we're doing now, but for providers. So we're calling it Pregnancy for Professionals because we have learned so much. Like we started this community just over 2 years ago. We literally started a month before the pandemic took off here, but we've learned so much about like nutrition, trauma-informed care, physio. Like we've learned so much that we're like, oh my gosh, we need to teach other providers everything we've learned. So we're building this community for providers that will hopefully share these experiences, and like providers can start to learn and understand the importance and like small changes that they can make in their practice that can hugely impact people's experiences.
That's amazing. I love hearing that.
Yeah.
I'll have to keep an eye out for that. That
Yeah.
sounds so cool.
It's called Pregnancy for Professional. And we have a sign up that you can just sign up to be notified when things start to go live. But yeah, and we're just going to start by sharing resources, and then who knows where it's going to go.
That's great.
Yeah. Amazing. Oh my gosh, what a great conversation. I love that.
Great.
Great. We'll just continue. Hopefully other providers were listening and can go continue to educate and inform their colleagues, and slowly we'll make change. I think we're doing well in Canada. We still do have a long way to go. And I think you'll see change in the US too.
I hope so. Yeah.
Awesome. Thanks for chatting with me today.
Yeah. Thank you. It was really nice meeting you.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.